problem we worry about is hypoglycemia. It has others, but that's the main problem. And it's cheap. It's on the $4 list. Okay, you can get 30 pills for $4. Cheap. Okay. These drugs have fallen out of favor. There's been all kinds of ways that people have looked at the drugs in terms of cardiac effect, and you'll hear lots of negatives. And so it's fallen down from being first line to second line to now other agents are preferred above it. But I'm telling you, if you've got somebody who is cash strapped and they can't afford, or insurance may say, you got to do these first before I go to these expensive agents. These are powerful agents. I love them. I think they get a bad rap. I understand that they feel that there's problems, but they are really powerful drugs. We don't use them in type 1 because they don't have any beta cells that produce insulin, so that makes sense. Diabetes and pancreatic resection, they might work, but they're not going to be very powerful because they probably will have some insulin-reduced ability. If they have strong, this would be very type 1 hypersensitivity to sulfa drugs, then these drugs, they could cross-react. I have only seen it twice in 30 years, so it's a very low risk. Stress, the problem with stress is that sugars go really high. When people are super stressed, you're going to have to use insulin. So that's the reason why it's a contraindication. It just ain't going to work that well. Significant renal or hepatic disease or predisposed to significant hypoglycemia. If I have an older person at home by themselves, they won't monitor, somebody who won't monitor and is older, if they're food insecure, I will tend to stay away from this drug because I'm too worried about the hypoglycemia. If you look down in that box, these are the three that are most commonly used. These are not all of them, but these are the three most common: glimepiride, glipizide, and glyburide. You can see they're dosed once or twice a day. Usually at higher doses, we split it up. But look over on the metabolism excretion. So some of these have metabolites that are active. Okay? So if they've got renal insufficiency, don't use those. That's one of the reasons why I usually stay away from glyburide in older people, because it has metabolites that are renally active, but it's a very long-acting drug. Hangs around for a long time, compared to glipizide, which is much shorter. So if I'm going to use one, I usually go to glipizide. The other problem I find with this drug is if people are very variable and erratic in how they eat. You really have to have somebody who's eating to take this drug because it will lower their blood sugar too much. So that's a problem because once you take it, it exerts that effect all day long whether you're eating or not. So consistent eaters tend to do better on these drugs than people who don't eat consistently. Expected drop, fasting 60 to 70. It's better than metformin. It's powerful, 1 to 2%. Now let's talk about the meglitinides. I love these drugs. I do. So meglitinides were developed as a way to address some of the problems with sulfonylureas. Meglitinides, which are in that little box there, there's repaglinide and metagelinide. Okay, so you see there is this receptor on the, it's called the SU receptor. This is where both sulfonylureas and meglitinides sit. Okay? They each attach to a little bit different part of the receptor. The good thing about meglitinides is they get on the receptor and then they get off the receptor. Okay? On and off quick, which means they do their job, and then they go away. So their duration of action is very short. So their likelihood of having to produce hypoglycemia is low. That's what I like about them. The downside is you have to take them when you eat. So adherence can be a problem especially if people are not very patterned in their eating. Of the two, I like repaglinide the most. It's a little bit more powerful. It has a wide dosing range. You can start with 0.5 milligram a day and work all the way up to 16 milligrams total. Take it with a meal, usually about, I think it's 30 minutes is what it's recommended before a meal. I usually start off with whatever it depends on what their blood sugars are, but usually I start off with at least twice a day with 2 meals. And then I'll add a third one if they're eating 3 big meals a day, or 3 standard meals a day. Starlix I look at as a weak sister, but I do tend to like it in older people where I just need a little bit. Where I would use, if they were younger, I would use a bolus insulin. I will use this as just a little bit of a way to tweak a blood sugar that's just going way too high after a meal. Now that's how I do. So that's an N of 1. Okay. So that's the benefit. If you've got people who have very erratic times of when they eat, or they don't know when they're going to eat, let's say they're on the road and they never know where they're going to stop, or you got these men who are operating big machinery and they go out in the country and they don't know where they're going to go and eat their next meal, that's what I like this drug for, because I know that if they take it and they eat, it isn't going to be around 6 hours later when they're not eating and they're out in the middle of nowhere. Okay? So that's what I like about these drugs. If I've got people getting, are having lows on a sulfonylurea and I really that's the drug I have to use, then I like, and they're having too many lows, I'll move them to agglutinin. You'll see there, the other thing I like about repaglinide is it's not cleared by the kidneys. So if I've got renal insufficiency and I need a drug that will lower blood sugar and they won't go to insulin, or I don't want to use insulin, I like this drug. It's 100% biliary excreted. Starlix is about the same. Still, it's renal, but it's so weak that it's just a little tweak. That's what I like it for. Okay. Common adverse effects. They're fairly infrequent. These are well tolerated drugs that can cause hypoglycemia, but for the most part, they are not going to do it anywhere to the degree that the sulfonylurea is. Any drug can cause GI. Derm, this is all low risk. They do have a sulfa structure, so they can cause hypersensitivity in people who have severe allergies to sulfa-containing medications. And low risk, so that goes more to the sulfonylureas. Okay, questions about those? It would not be a class of drugs I would toss out because they're cheap and they work and they're powerful. Okay, TZDs. Thiazolidinediones. Their triglyceride was in this category. It came on the market probably in the 80s. Caused too much liver disease. People died of liver failure. They took it off. Next drug came on is rosiglitazone. Rosiglitazone was the one that had all the cardio toxicity, and they did not take it off the market, but they severely restricted it. And then was pioglitazone. So pioglitazone has survived, but it has lots of side effects. So this was a drug class that had great hope. It is the one that increases insulin sensitivity. So initially it came out so that you could use it with people on insulin and greatly increase their sensitivity to the drug, to insulin, and lower the amount that you had to use. These drugs work on increasing the GLUT4 transport molecules to the cell surface so that you can get more glucose into the cell. They belong to a class of drugs called the PPARs. These are peroxisome, forgotten what it stands for. But these bodies are everywhere, and they're subtypes everywhere. They are nuclear receptors. There's alpha, beta, delta, gamma, they're everywhere. And almost all the time when they are used, or drugs are developed, there's always problems. But they are sought after because they are so ubiquitous and they control such major functions in the body. So these came about and started being used, but the side effects have really limited their use. So number one thing, keep in mind, is they precipitate heart failure. They can cause new heart failure, or they can cause worsening of existing heart failure. You'll find a lot of cardiologists will still use them in people who have well-controlled heart failure, but they can precipitate new. They can cause anemia. They don't cause you to lose red blood cells, but because they cause fluid retention, they tend to cause a dilutional anemia, to the point where people get symptomatic. I've seen anemias of 9 and 10 grams per deciliter on this drug. So it's dilutional. Impaired liver function, not so much with the older agent, the newer, like pioglitazone. Triglyazone was bad, killed livers, they took it off the market. We don't use it in type 1, don't use it in pregnancy. It has no place, it has no power, very low power. So what can you expect? Well, one of the problems with this class of drugs is that it takes time. So it takes about 3 months to see effect. So that's one thing to keep in mind. The average A1C decrease is 1.5%, but the range in the literature is very wide, from 0.8 up to about 1.3 is about average. So I think they over-report. I have not found, now this is my own experience, I have not found this drug to be very helpful except in people who are newly diagnosed. Tend to do better. But when I have found trying to add it later in when people have had advanced disease, I have not found it to be as effective. That's my experience. Some people love it. Here's why I have trouble with it, under the other side effects. Weight gain is huge. It's about 10 to 15 pounds, average, but I have seen people gain 30 plus pounds, a lot. Now they'll tell you that it is mostly subcutaneous fat and it's not visceral fat, so it's not bad fat, but fat is fat for most people, especially women. So I have a great deal of difficulty with that. Edema, it's significant. They all come in complaining, look at my legs, look at my calves. They will get they can have big fluid retention. That's what also leads to the heart failure in those who are at risk. You can see macular edema in patients who are at risk in the eyeballs on this. Anemia is that dilutional effect. It goes along with that fluid retention. So just beware. Heart failure and exacerbations of heart failure, talked about that. The odds ratio is 2.1 risk for heart failure compared to placebo. That's big. That's a big relative risk. It occurs at any dosage level. It usually occurs after several months of treatment. Average onset was about 6 months. Skeletal defects. It increases the risk of fractures in women. So they did this big study, and the study was not on skeletal fractures from the rosiglitazone. It was on cardiovascular and diabetes effects. And what they found in these sub-analyses is that these women were having more wrist fractures, more humeral fractures. So Remember, PPARs are in the bone. So they increase bone loss, they increase osteoclastic activity, and so they resorb on bone. So they, over time, long-term use, they break down bone. Increased risk of heart disease with pioglitazone, small increase in MIs and cardiovascular disease. It's like, how do you sell the drug? Turn off, turn off. I don't want what I'm going to say.